Yeah, I can hear you now.
Oh, good, good. So my talk will be primarily about waveforms analysis, talk about some practical points regarding, indication use of PA catheter, what you might expect to see on board exam. So this is the first part of my talk, and tomorrow there will be some questions that has come, over years through the pulmonary or the critical care board. So things that you need to know for the test also. So just some history background, going back around 200 years, first time actually cardiac cath was done on an animal. It was done on a horse. Dr. Bernard, he put like glass tubes in the internal carotid and in the jugular vein, in a horse. But as far as in a human being, clinical application began in 1930. It was a physician. His name is Dr. Forsman. He did it actually on himself. So he put a catheter and he guided the catheter inside his right atrium, and he confirmed that it was in the heart. He took, fluoroscopy and confirmed that it was in the right atrium. But as far as clinical use of PA catheter goes back to 1970. And so you will hear, different terminology, PA catheter, right heart cath, Swan-Ganz catheter, all, are the same, but Swan-Ganz, because it refers to the two physicians from Cedars-Sinai and UCLA, Dr. Swan and Dr. Ganz, who invented the PA catheter for clinical use. And over the year, there had been refinement in the PA catheter. So that's the first version in 1970, and then there was a thermodilution that was added, and furthermore, other features were incorporated. So now you have Swan-Ganz that has option of having continuous oximetry. So instead of intermittent sampling of mixed venous blood from PA catheter, you can have the option of having continuous oximetric measurement displayed on the screen all the time. And there is newer catheters that can measures for you the right ventricular ejection fraction and right ventricular is called volumetric Swan-Ganz. So they give you more information, beyond the original hemodynamic data that was first used. As far as indication of the Swan-Ganz, and there are studies and controversy about, using the Swan-Ganz, and that came from studies actually in the 80s that showed that there was some association between worse outcome of patients who had received, Swan-Ganz versus the ones who did not, whether this was directly, attributed to the Swan-Ganz itself, or whether it has to do, with the patients being, too sick who had required Swan-Ganz placement, or it might have to do with the way that the data were acquired and the data, how they were applied, to the patient's care. So, and I think, a lot of that has to do with the last point. But nonetheless, Swan-Ganz used to be very common procedure to be done. When I did my critical care, we'll do it, daily. When I'm on call, we'll have multiple Swan-Ganz placed. So situation has changed since then, and so you don't see it done too often. More so these days, maybe an evaluation of patients with pulmonary hypertension. Sometimes you see it in cardiac ICU on patients coming, off major cardiac or vascular surgery. But nonetheless, you can look at the indications under two categories. It can be done for diagnostic purpose, mainly for patients who have pulmonary edema or shock that is, you are unable to categorize or to differentiate based on your clinical evaluation. So Swan-Ganz might be of help in that respect. And like I said, it's an essential component of evaluating patients with pulmonary hypertension. So at the time of diagnosis, and you might have to repeat it, as patients are placed on therapies to see how they respond to therapy. It does have a role in patients with pericardial disease, like, constrictive pericarditis or tamponade, or patients, with restrictive cardiomyopathy. And we'll talk about the waveforms that will be, suggestive of one diagnosis versus the other. Also in patients with intracardiac shunt, And in patients, going for transplant evaluation, cardiac patients going for transplant, they usually go for right heart cath. In certain patients with liver transplant, if they are suspected to have portal pulmonary hypertension, or if they have abnormal echo, which is part of their evaluation, they receive right heart catheterization, because these patients carries high operative surgical risk, and many centers may disqualify them, or they might, put them under treatment to bring their pressures down before they proceed with orthotopic liver transplant. So that's from the diagnostic indication. As far as therapeutic indication, again, in the ICU, it can have some utility in guiding your therapy if patients have uncertain volume status, and we'll talk about, limitations and pitfalls of Swan-Ganz in that respect, or patients having complicated MI, or like I said, patients in shock, or patients with refractory heart failure whom they have been tried on therapy and they are still not responding the way that you expect. So Swan-Ganz can be of help, and this is where you might encounter it in the ICU, and like I said, more so in patients who comes, with the pulmonary hypertension evaluation. And I think Dr. Lastal, he expanded on that, right? There were some sessions about pulmonary hypertension.
Yes.
Yes.
He did? Okay, all right. Like I said, it's, a common modality in pulmonary hypertension. There have been changes in the definition. This is the big category, pulmonary hypertension, where you require the mean pulmonary artery pressure now to be less than 20 or more than 20 instead of 25. So it used to be 25. There had been revision in definitions. So now the requirement is 20 or more. In patients with group 1, which is the group where, all the studies about vasodilators was directed, you have to have wedge less than 15 and BVR more than a 3 Wood unit. And then the vast majority of patients are non-category A, or they belong to category 2, which is patients with cardiac disease. And we have one patient in the unit now. So this could be, preserved ejection fraction heart failure, or reduced ejection fraction heart failure. Once you might, encounter someone coming to the unit with right side endocarditis and develop, pulmonary edema and shock. So keep in mind that this is a big contraindication or absolute contraindication, or patients have suspected tumor on the right side of the heart or masses, because, you run the risk of dislodging tissue into the pulmonary artery. So no for Swan-Ganz in that setting. There are some relative contraindications. The patients have uncorrectable severe coagulopathy or thrombocytopenia. This might be a relative contraindication. And in patients with left bundle branch block, and you might be asked about that, you have to be careful and putting a swan in these patients, because swan can induce right bundle branch block, leading, to complete heart block. So you have to be ready for putting, transvenous pacemaker. Actually, the swan, like I'm going to show you, it has a port where you can put a pacer lead into the right ventricle, should you encounter heart block while you're passing the swan. Swan-Ganz can be done at the bedside. It can be done in the cath lab, where you have access to fluoroscopy. But at the bedside, you can do it without a fluoroscopy, based on the waveform that we're going to discuss. Now, if patients have valvular problems, especially tricuspid regurg, if you have dilated right ventricle, you might encounter difficulty floating the swan, because, the regurgitant blood tends to bring the catheter back to the right atrium, or it might induce, coiling into the ventricle if the ventricle is dilated and hypokinetic. And in that instant, fluoroscopy would be of help, to guide your catheter to where it should be. As far as places where to put this one, and you've seen that, some of you have done that. So the neck, the right side of the neck, right IJ, is the best place, to pass your catheter. It's a straight path to the right atrium. If you put a subclavian approach, the left subclavian vein will be better than the right side, because also it goes more straight towards the right side of the heart. Swan-Ganz can be put through a femoral approach, and I think they do that sometimes down in the cath lab. And in that case, you need a fluoroscopy, because you have to maneuver retrograde through the IVC into the right atrium. So fluoroscopy would be needed in that case. But the IJ, with ultrasound guidance would be the better approach. Okay, you are familiar with the catheter, and there's two used catheters here. You can pass it around when we finish, and if you have questions, I can go over this. But as far as the structure of the catheter, different from the CVB, lengthwise, because of the distance it has to traverse, typically 110 centimeter. And then you have stripes, black stripes that indicate the distance. Each is 10 centimeter, and there is a wide stripe that would be 50 centimeter. So that's on the catheter itself. Now there are different ports for this one here. There is one that goes at the tip, and this is where you put your syringe and inflate the balloon as you advance this one. So the balloon would be at the tip of the catheter, and you want to check the balloon before you put it in to make sure that your balloon is intact. Now the blue one here is the CVB port. So this opens at about 30 centimeter from the tip of the catheter. The yellow one opens at the tip of the catheter. That's the PA distal. And this is an extra port where you can use it for infusion. Like I said, you can put a pacer lead through this extra port. And this is where you attach it to the cardiac output computer. So this goes to the cardiac output. So that's basically, the structure of this one, GANs. And like I said, there's different versions. Some of them have options, for oximetry. Some have options for measurement of right ventricular volume or ejection fraction. Okay, that's just another picture. And again, you check, make sure your balloon is intact before you put it in. And the catheter goes in through a sterile sleeve. So you have to make sure. So if you need to manipulate the catheter from outside after you put it in, it will be sterile. You won't touch the catheter directly. And we've seen patients coming back sometimes from the cath lab with the catheter without sterile sheath. So it's very important to maintain, the sterility, because there is risk of infection with the PA catheter, even maybe more than the central venous catheter. The longer it stays, there's risk, of infection. And we've seen patients having bacteremia with this one in place. But that's the sterile sheath that you that will house your catheter as you pass it in. And here there's a side port where you can use it for infusion. So that's basically how it looks like. And like I said, you're familiar with that. Now, important, for practical purposes is the concept of leveling and zeroing, because if you don't do that, your measurements can be erroneous, and you can get, false information and potentially, apply it in the harmful way to the patient. So the pressure transducer is leveled, and it's called the phlebostactic axis, and that corresponds to the mid-axillary line, fourth intercostal space. That corresponds to the level of the right atrium. So this is where you will level, and the nurses will help you with that, with the setup, but you want to make sure when you do your measurement that you are leveled at that reference point. And the other thing, of course, before you get your measurement is the concept of zeroing. So there's a stopcock here. So the stopcock is closed towards the patient, and then you open the stopcock here. So it's open to the atmosphere here. And this is your reference pressure point. So atmospheric pressure 760 is your reference point. And then on the screen, it gives you, the prompt to push 0. So you push 0 on the screen, and then your system will be leveled and will be zeroed. So that's important. So again, yeah, that's the meaning of zeroing. Like I said, you reference your measurement to the atmospheric pressure using the stopcock. And that's, again, the phlebostactic axis, fourth intercostal space, mid-axillary line, corresponding to the right atrium. It does not change whether the patient are supine, whether patients are, semi-recumbent. Your reference point is the same. So that's your reference point that you use. Now, then you float your catheter, of course, like I said, at the bedside. You do it, patients, on the monitor, of course, and then you look at your waveforms that we'll discuss, going, from the right atrium. These are the normal pressure, 0 to 5, but can be up to 8. And the RV here, as you transition from the RA to the CVB, you see the change in the morphology of the waveform. And as you get out from the RV to the PA, you see what we call diastolic step up. So there's the RV diastolic pressure usually is low, but as you get into the pulmonary artery, you see increase in diastolic pressure. Your systolic pressure will be the same. And you see the dichrotic notch here, which corresponds to the pulmonary valve closure. And as you come out, see if we can get this away, to the PA catheter, you see waveforms that look similar to the RA because that correlates or refer to left atrial waveforms. But that's again, as you float your swan, and when things goes fine and when you don't have trouble with dilated ventricle or tricuspid regurg, usually you go in, you will be, in the wedge position within like a minute or less than a minute. So it goes very quickly. Sometimes, of course, you can encounter some difficulties, and I'll show you an example, but that might have to do with the anatomy. But that's the typical sequence of waveforms as you traverse, the right atrium across the tricuspid valve into the RV, out to the PA, and further out with the balloon inflated to the wedge position. Okay, so what we try to do, with this one in place, with the balloon inflated, you basically have a continuous column of blood that extends from the tip of the catheter to the left atrium. So you're basically looking, this one Gans is looking into the left atrium through the pulmonary circuit. So this wedge pressure or occlusion pressure is indirect surrogate or indirect measurement for left atrial pressure with certain limitations that I also will discuss. Okay, but that's the concept again. This is your balloon here. That's the left atrium. We call this the J point. This is continuous column of blood. And once the balloon is inflated, your wedge will reflect the left atrial pressure. That's with a lot of assumptions. So you assume that there is no intrinsic pulmonary vascular disease, like, patients have condition rare called veno-occlusive pulmonary disease. There could be a discrepancy between the wedge and the left atrial pressure. Or if you have mitral valve disease, like mitral stenosis or regurgitation, there could be a discrepancy between the left atrial pressure and the left ventricular pressure, because you're trying, to measure the left atrial pressure, which will correlate with the left ventricular and diastolic pressure, and indirectly into left ventricular diastolic volume, telling you, somewhat about volume status. So these limitations has to be kept in mind. As far as the distance, like I said, this is labeled on this one Gans, depending where you access your heart. If you go from the right side, of course, there will be less distance required. If you go from the left side or from the groin, there will be more distance. But typically within 15 to 20 centimeter, you should be seeing CVB waveforms. So you go in, you see the CVB waveforms. Once you are there, you inflate your balloon and you advance it. So the balloon should be inflated as you go in to avoid injury, to the myocardium or endocardium and the valves. 5-10 centimeters further, you should be in the right ventricle, and you see this step up in the systolic pressure. And another 5 to 10 centimeter, you see the pulmonary artery waveform. You take it back, 5 centimeters to 10 centimeters, you should be in a wedge. Now, if you don't, and if you keep seeing, the same waveform, like if you're seeing the RV waveform and you are 40 centimeters, you should suspect that you're probably coiling into the ventricle. And in that case, you deflate your balloon and you pull back and inflate it again and re-advance it. And if there's persistent difficulties, then a fluoroscopy would be needed, to aid you with that. But these are the typical distance landmarks. And of course, when you finish, you do X-ray. If you are in fluoroscopy, you can do fluoroscopy and you can, confirm where your catheter is ending, but that's the typical location. There's a patient with edema. You see the catheter going in here, coiling, and usually it favors the right pulmonary artery. Sometimes it might go to the left side, but most of the time it goes to the right pulmonary artery. And this is where you want your catheter to be. So you want it to be not crossing the descending part of the catheter, because it will be further out and we'll talk about the potential risk and complication from that. But if you are in a proximal position here,
That's wrong.
right, and then you will know that you are in a proximal location because it will take you the full amount of air, usually 1.25, 1.5 centimeter to get the wedge. So if you get your wedge with smaller amount, you know that your catheter is further out, so you retract it back and you re-advance it at the new distance. Okay, now what you get from the catheter as far as measurement, several things. So, there's no doubt that there's a plethora of information that you gather from the Swan gas that you can't get it, any other way. So some of these are directly measured parameters, some of these are calculated. So, the directly measured ones, of course, is right atrial pressure or CVB, RVSP, and you get that as you pass your catheter. So that's the only time, because you don't want to stay too long in the RV. You pass the RV quickly, otherwise you will induce arrhythmia. But as you pass your catheter, you measure the RVSP and the RVDB, the diastolic and systolic pressure of the right ventricle. And then, of course, your pulmonary artery, where you measure systolic, diastolic, and then the mean pressure will be calculation. And then your wedge pressure or occlusion pressure and the saturations. You can do it from, all the chambers, and then the cardiac output. And then you derive your index from that. And then you get the other calculations. So which will include, your SVR, your pulmonary vascular resistance. Like I showed you, this is one of the definition for or criteria for pulmonary hypertension. And then the transpulmonary gradient that we'll discuss. So this would be the normal measurements, 20 to 30 for PA pressure, 8 to 12 with a mean less than 20. We talk about the RA, which can be variable, but can be from 0 to 8. RV similar to the PA and systolic, but much lower diastolic. And then your wedge usually less than 12 to 14. 14 is the maximum normal. Now the TPG is an important term. It's a transpulmonary gradient. So that refers to the pressure gradient across the pulmonary circulation, which will be the mean pulmonary artery pressure minus wedge pressure. So this is what drives the blood across the heart. And from that, you get your PVR. So the PVR, pulmonary vascular resistance. So resistance is a pressure overflow, which is the cardiac output. And then that gives you in Wood unit. Normal will be less than 3, more than 3 is what you require for pulmonary hypertension. And if you multiply it by 80, you convert it from Wood unit to the dyne second centimeter. Now the SVR, you calculate the SVR by your upstream pressure is mean arterial pressure, your downstream pressure is right atrial pressure. So the pressure gradient over the cardiac output multiplied by 80 gives you the SVR in dyne normally will be less than 1100, 800 to 1100. And then your cardiac output 4 to 7, 4 to 8 liters normally. Now I'll talk also about arterial catheter, because we do that often, usually in conjunction or without Swan gas, but this is something that we do often. So accepted indications, patients on vasoactive medications, whether antihypertensive or vasopressors requiring titration. Arterial catheter is very helpful, or patients have hemodynamic instability and stable blood pressure, or sometimes you might need it for frequent ABGs or labs, or because of patients' body habitus or anatomic considerations, you may not be able to obtain reliable non-invasive readings, and we see that often. So in that case, you want to have arterial catheters, so you want to make sure that you titrate your medications to an accurate reading. I find it very helpful when patients have arterial catheter. Patients goes to have hemodynamic instability or the sustained cardiac arrest, and you have a catheter in place. It's very helpful to monitor your the way that you do your CBR, or patients have ROSC. You will see it on your arterial catheter. So it's helpful also when it's in place during resuscitation. Okay, the setup again, the nurses will put that for you, but you should be familiar. That's your pressure transducer. And this is where it's attached to your arterial catheter, and you have a stopcock here. And the same concept, with leveling and zeroing, like you do it for this one, you do it for the arterial catheter. And then here, where you attach it to the pressurized bag, and this is what goes on the screen. So that's the part that connects to the monitor and gives you the arterial waveform. And this small thread, the blue thread, is, and I'll show you, the concept of rapid flush test, just, to, right, to overshoot, any problems, to look for square waveforms or the rapid flush test. But again, that's the setup. Again, you got saline here, and there is a pressurized bag that's usually inflated up to 300 millimeter mercury. That's the holder for transducer, where you level it with the patient's mid-axillary line, and that's the cable that's attached to the monitor screen. So again, it's important, for validity of readings, that you make sure that the bag is fully inflated, that the system is leveled and zeroed, and we'll talk about the square wave test, which should be done, routinely once, at least every shift. But if you suspect, erroneous reading, or the waveform doesn't look normal or distorted, like we're going to discuss, you have to troubleshoot your system by doing the flush test or square waveform. Okay. CVB, of course, is measurement of central venous pressure. We talk about, controversy or limitation as far as reflection of volume status. It does have limitation, and there are studies that showing that it does not correlate, with the volume status. So as a static measurement, it does not help you in that respect. It's used, in the ICU, of course, for, venous access, or patients are on pressors or hypertonic, or, TBN. It's required for that reason. But as such, it does not really reflect, cardiac function or volume status. So again, the fluid balance, circulating blood, heart function, circulatory failure, CVB does not give you accurate measurements. And we did talk about the normals. Now, if you want to convert CVB, like if you're measuring JVD in centimeters, that's the conversion. So millimeter times 1.36 gives you a centimeter H2O for CVB. And the setup is similar to the arterial catheter, transducer, and the cable here, and the pressurized bag. And it says same concept, with leveling and zeroing. Okay, so this is the fast flush or square wave test. So what you do, basically, you pull back on that blue string, and when you do, you open the system. So the system is open, your catheter is exposed to the upstream pressure that comes from the pressurized bag. So that's 300 millimeter mercury. So when you do that, you look at the screen and you see the pressure goes above the screen and gives you this square wave. That's why it's called a square wave test or rapid flush test. So it's just to check that your system is working. That's, what we call a dynamic response test, and to make sure that the system is optimally damped. This is what we call optimal damping. That's the normal appearance of the waveform. So if you don't see, the diacritic notch in systolic and diastolic, if the waveform looks, like rounded, or you don't see this configuration or this morphology, you want to make sure that your system is working by, doing the rapid flush test. So when you pull back, you see the pressure, like I said, overshoot, and when you let go, you're going to see 1 to 2 oscillations. And that's the optimally damped system. So the system can be over damped, and that's a common case scenario. So if you have kinking, if you have, some air bubbles, if you have some, tissue or something coming and blocking your catheter, your waveform becomes rounded like this. You don't see the systolic upstroke. You lose your diacritic notch, and that results in overestimation of the diastolic pressure and underestimation of your systolic pressure. And when you release your pressure here, you're not going to see the oscillation. Now, the system can be underdamped, and that can be seen if you have excessively lengthy tubing, or if the tubing is not stiff. So the tubing that should go with the catheter should be stiff. Otherwise, you're going to encounter underdamping, and you see that as an overestimation of the systolic pressure and underestimation of the diastolic pressure. And when you let go, you're going to see multiple oscillations. Instead of no oscillation with the damped system, you see multiple oscillation. So that's another thing. So again, the damping, as far as a concept, like I said, it's an inherent tendency for the system. So as the wave or the signal is transferred or transmitted from the patient to the transducer, there will be some tendency, to alter the pressure. And that's here the concept of the damping coefficient and natural frequency. And this is where you want your system to be. This is what we call optimally dynamic response. If not, you might be encountered either over-damped or under-damped system with the waveform having different appearance or configuration. The other thing, like I said, leveling your system to the right atrium can impact or can affect your readings. So if you put your system above, you can underestimate your reading. So if you are 10 centimeters above your measured reading, here the true reading is 12. And if you convert that by 1.36 centimeter, that's about 8 millimeter less. So your wedge will be read as 4 instead of 12. So if you're looking for a patient for pulmonary hypertension, you can miscategorize them. Like if you put it at lower level, like 10 centimeter, that will overestimate your reading. So that can take you from 12 to 20, putting you on someone who you think might have type 2 pulmonary hypertension. So it's important that you are leveled so you don't have this issue with either over or under reading your wedge pressure. Okay, so as far as waveform analysis, how the waveforms are produced or what makes the waveforms, it has to do, of course, with the blood either coming or leaving chamber, atrium or ventricle. The other thing that affects the waveform is the wall tension, which is basically, either the atrium or the ventricle, whether they are stiff, whether they are compliant, the amount of contraction, relaxation, all of that can affect your waveforms, and we'll show you examples about that. Other thing to keep in mind that the electrical stimulation of the heart precedes the mechanical event. So the signal is transmitted first, and then you're going to see the mechanical event, will, for example, like the PR interval. And then when the atrium contracts, the contraction mechanical event will show after the electrical event. So, and that will show, that's why when you look at your measurement, you have to take both EKG tracing with the pressure tracing at the same time, and you will time it. And again, we'll discuss that at length. The other thing to keep in mind that beside the amount of blood that comes and leaves the cardiac chambers, and beside the status of the cardiac chambers, there's external factors that affect your pressure measurement. And this could be inside the chest. For example, if patients are on high level of PEEP, or if there's increase in intrathoracic pressure, or if there's blockage, or even if patients have intra-abdominal hypertension, some of that can be transmitted to the chest, and it can lead to false high CVB or wedge readings. So you have to keep that in mind. Okay, this is the CVB, the typical components that you are familiar with. So you have the 3 peaks, and you have 2 values. So the AC and V are the positive waves, and then the X and the Y are the negative ones. And like I said, the A wave comes after the PR interval here. The C wave, the A wave is the contraction of the atrium. The C wave, when the so that will correlate with the R wave here. And then the X, when the atrium relax during systole, when the ventricle is in systole. So it gives you this negative deflection. And then the V, when the atrium is filling up. So that will be at the end of the ventricular diastole, which will be after the T wave. Then the Y, just before the end of the ventricular diastole, when the atrium gives you the atrial kick and the atrium, empties, so that will cause the pressure to go down. So again, this of the atrium, and if you correlate that with your EKG, it will come after the PR intervals. That's the waveform. If you correlate that with your arterial waveform, it comes at the end of diastole. So this is when you have the kick, which gives you like 20-30% of the cardiac output. Like I said, the C wave is the beginning of contraction of the ventricle as the tricuspid valve goes into the right atrium. So you see it here, and that gives you another positive wave. And then you got the X wave when the atrium is relaxed. So you see drop in the pressure. So that's also towards mid-systole. And then V wave, which is the other positive wave at the late systole when the atrium is filling up. And then lastly, at the end of ventricular diastole, when the tricuspid valve opens and the blood goes from the atrium to the ventricle, so you have this wide descent. And there will be some abnormalities in certain conditions that we'll discuss that will affect these waveforms. But again, this is just summary for your waveforms in the CVB, the three peaks, the A, C, and V, atrial contraction, closure of tricuspid valve for C, and V wave is the atrial filling. And then the two descents, the X from atrial relaxation and the Y with the tricuspid valve opening. And this is how you time it with the cardiac cycle. So A after the PR interval, and then C in systole, and then you get X also in late systole, then V during ventricular systole, and Y towards the end when the tricuspid valve opens. Okay. Like I said, you plot your pressure waveform, but you have to have concomitantly the EKG tracing. So you can't time it. Don't depend on digital reading. It's always good to have printed waveform, so you can time your wave to the cycle of to the cardiac cycle. Like I said, the atrial, the A waves comes after the PR. So the electrical events precede the mechanical events. Then the C wave, because it reflects ventricular contraction, so it corresponds to the R and the QRS. Then comes the V wave, which is the atrial filling. So this comes after the T wave. So that's the normal on the right side, and on the left side it will have different appearance that I'll show you on the wedge. But that's for the CVB. So C wave after PR, A wave after PR, C wave at R, then V wave after the T wave on the EKG. Okay, and this again, just to summarize again, the A wave when the atrium contracts, so the tricuspid valve will be opened, and then the X descent, which is relaxation of the atrium, and the V, which is filling up of the right atrium, so the valve will be closed, and the Y when the tricuspid valve opens again, so you have the wide descent. Okay, like I said, CVB has limitation as far as assessing cardiac function or volume status. Is not the way to go, and that has to do with other factors that can affect your CVB. So beside the volume, the RV and LV function can affect your CVB measurement. The other thing is venous capacitance. For example, if patients are on depressors, that will increase the mean systemic filling pressure, and that will cause your CVB to be elevated, not because of the volume, but because of the upstream pressure being increased by pressors used for the patient. We did discuss the mechanical ventilation, especially if they are on high level of PEEP, ventricular compliance, right atrial pressure. So the CVB can be raised not only because of hypervolemia or heart failure, but if you have valve issues, tricuspid stenosis or regurgitation, if you have pericardial disease, effusion, or constrictive pericarditis, that can elevate your CVB, or if you have SVC obstruction, hyperdynamic situation, and the high PEEP settings. Right, and that's summarized here in this picture. Like I said, these external factors that you have to keep in mind when you are measuring your CVB, making it not, valid reflection for volume or for cardiac function because of all these interfering, factors. Okay, this is just, to stress again the CVB with the cardiac cycle, the A after PR interval, C with R, V after T, and then the Y after that. So again, this is an example, where you put your EKG and your CVB reading. So you take the A wave, average A wave, which comes after PR, and the average A wave is your CVB. Now, if patients have atrial fibrillation, that's an issue. So you won't be able. But and the other thing, you measure your CVB at the end of expiration. The same thing applies for this one when I show you this one measurements. So whether patients are breathing on their own or if they are on the vent, you have to time your measurement at the end of expiration. So that's an example for measuring the end of expiration here. End of expiration, patient on mechanical ventilation. So if you do it here, it will be falsely high. Now, I did mention about, lack of correlation between CVB and volume status, but this is one of the studies that came, almost 30, 40 years ago. So it looks at CVB and here volume, no euvolemia, here hypovolemia and hypervolemia, and you see the numbers is all over the place. So patients can have low or normal CVB and they can be, volume overloaded, or they can be, euvolemic, or they can be, volume depleted. So, okay, the RV waveform, like I said, when you go from the right atrium to the right ventricle, you see the upstroke here, the systolic pressure. The diastolic pressure usually is low in the right ventricle, usually between 0 and 8, but that's how it correlates with the EKG. So the QRS reflects the ventricular depolarization or contraction. So this is where you see the systolic RV pressure, and then here's the end diastolic pressure. Okay, this is again how it looks on real life. So this is EKG, this is RV systolic pressure and diastolic pressure. Like I said, when you transition from the right ventricle to the pulmonary artery, by change in your diastolic pressure, right? The diastolic step up here. So systolic pressure is the same between RV and PA, assuming you have no pulmonary valve disease, but the diastolic pressure is what goes higher when you transition from the RV to the PA. And with that, you will see also the dichrotic notch. So that's again the PA systolic, PA diastolic, and you time it to the cardiac cycle. Your PA systolic comes after the T wave. Now, as you advance your catheter further, you go from the PA catheter, from the PA to the wedge position. You see change in the shape or morphology of the waveform. Looks somewhat similar to the RA waveform. You won't be able to screen a C wave. Yeah, the most easily seen waves is the A and the V, but it looks somewhat similar to the CVB waveform. Okay, so that's difference between the wedge and the CVB, and you see the waves comes later in the cardiac cycle, and that has to do with the fact that the signal has to traverse from the left side of the heart across the catheter, so you see it later in the cardiac cycle. For example, the A, here you see it after the QRS instead of after being the PR interval, and you see the V wave moved further later in the cardiac cycle just before TP, so in the TP interval. Okay, again, this is showing, the correlation. The A is the atrial contraction, like with CVB. C, which is not easily seen, the closure of the mitral valve, and V is the filling of the left atrium, except that you see it again showing later in the cardiac cycle after the T wave, just before the P wave. and the wedge waveform as it correlates with the EKG. You see things are moved towards the right side, bringing your A wave after the QRS and bringing your V wave further just before the P wave. So you can see large A waves. The patients have valve disease, tricuspid or mitral regurg, that will produce, large A waves, and sometimes it will fuse with the V wave. Or if patients have, AV asynchrony or dysynchrony, so you'll see a giant waveform like in junctional rhythm or in tachycardia. In AFib, of course, you don't see a atrial waveform, or patients have based rhythm or patients have ventricular arrhythmia, you lose the A wave. The V wave can be, exaggerated from tricuspid or mitral regurg, or if the atrium is stiff, it will produce larger V waves, or if you have, a core pulmonale, of course, that will produce large V waves. Of course, you lose it. If patients have, VFib or RBA, you don't see a V wave. So that's an example of patient with mitral regurg. You see a giant V wave. This is the A wave. After patient is treated, you're going to see the V wave becoming, of a smaller size. Tomorrow session, in some questions, you see larger V waves. And in these patients, of course, when you put your swan and you measure your saturations, you're going to see step up in the saturations as you go from the right atrium to the right ventricle, reflecting the mixed blood or the blood coming from the left side. The cardiac tamponade is something else that you might see showing on exam. So with cardiac tamponade, you're going to see increase in the pressure. So all the pressures will be increased to the same level. But then on this one, or on the PA catheter, you're going to see blunting of the Y descent. And that has to do with the pressure increase around the heart. So that will attenuate the blood as it goes from the atrium to the ventricle. Because of the raised pressure, there will be attenuation of the Y wave. Now, constrictive pericarditis is the other condition that can be mixed or confused with cardiac tamponade. So different from tamponade. So in both conditions, you'll see increase in the pressures. And with the constrictive pericarditis, you will see a steep Y instead of blunted Y, like you see with the cardiac tamponade. So again, here is cardiac tamponade, this pericardic constriction, this is normal. In tamponade, you see blunting of the Y descent. In constrictive pericarditis, you're going to see exaggerated Y descent. Okay, we did go over this. As far as the waveforms, what we call canon A wave, like I said, with AV dissociation, the tall A wave with increased atrial pressure, you lose it with atrial fibrillation. To talk about the giant V waves that you see with mitral or tricuspid regurg or VSD, we did discuss the loss of Y descent in tamponade and exaggerated the opposite in the constrictive. Cardiac cycle. Try to finish in 5 minutes. And so this is the left ventricle, and you see the different phases. This is what we call isovolumetric contraction. So at the beginning of the systole, the mitral valve will close, but the blood still will be in the ventricle. So the size or the volume of the ventricle will be the same. That's why we call it isovolumetric. The pressure will be increased. As the pressure exceeds the aortic pressure, the aortic valve will open. So here is the mitral valve close. Here, once the pressure goes above the aortic pressure, the valve will open and the blood will be ejected. So this is an ejection phase. The blood will be ejected and then the pressure will go down. And once it's less than the aortic pressure, the aortic valve will close. So that will finish your systole, and this is the end diastole. And the difference between the two, of course, is the stroke volume. So end systolic volume minus end diastolic volume gives you the stroke volume. But this is how it looks like here on the EKG. So this will be an S1, the first heart sound. This will be the R wave, which correspond to the ventricular depolarization or the ventricular contraction. And this is end diastole, when the AV valve will open again and the ventricle will fill up, and then the next cycle comes on. So that's again the concept of the pressure volume loops. That's left ventricular pressure. This is the volume, and this is the end systolic volume, and this is the phase of the contraction with no change in the volume, the isovolumetric contraction. And here, when you have the emptying of the ventricle, this is end of systole, and this is end diastolic volume, which reflects, it's the actual what reflects the preload. It's not the pressure, the volume. But this is your stroke volume, the difference between the two. Okay, I'll talk briefly about cardiac output, and we'll continue tomorrow with a few more slides than the questions part. But the cardiac output is another thing that's important that you can get from this one. We did discuss that earlier today during our rounds in the IC, but there is 3 ways to do the measurement. There is the dye indicator dilution technique. The clinical way of doing it is either with the Fick's equation or with the thermal dilution. Now, the Fick's technique, has to do with the oxygen consumption formula. So your cardiac output will be the oxygen consumption over the arterial mixed venous oxygen difference. A normal VO2 max, VO2 is like 250 ml, and then you do the calculation here and you get your cardiac output. This is accurate, more accurate, is considered gold standard, especially in low cardiac output status. The thermodilution technique depends on injecting certain amount of saline with a known temperature. So we inject that in the right atrium through the CVB port, and then the blood will go to the right ventricle, to the pulmonary artery, it will mixes, and then the temperature will be changed. So you see the temperature difference that has to do with the flow of the blood. So the temperature difference is a function of the flow of the blood, which is basically the cardiac output. Now, this has limitation. If you have someone with VSD, so your measurement is not valid. If you have a patient with a tricuspid regurgitation, your cardiac output measurement based or using the thermodilution is not going to be accurate, because the blood will come back to the right atrium and you won't be able to rely on the temperature difference. Now, the mixed venous saturation is a surrogate. Using the Fick's equation is a surrogate for the cardiac output. But again, you have to keep in mind that there are conditions that will affect your reading. If patients are septic, your mixed venous saturations can be normal or can be high because of issue, not with oxygen delivery, but because of issue with peripheral tissue utilization. But outside that, it's used as indirect or as a surrogate for the cardiac output. And this is how it looks, on the screen when you use the thermodilution. So you put the saline, and then this will be the shape of the curve. And depending on the area of the curve, there will be a cardiac output computed by the computer. Okay, so points to remember, like I said, the intrathoracic pressure affects your reading. Your measurement should be at the end of expiration, whether patients are on the vent or breathing on their own. These are the equations to talk about the cardiac output, stroke volume times heart rate, or end systolic minus end diastolic volume times heart rate. And that's the stroke volume. And then your compliance of the ventricle, volume over pressure. Your resistance is pressure over flow. So for SVR, mean arterial pressure; for PVR, mean pulmonary artery pressure; and for the first one, CVB, and for the BVR is the wedge pressure. And when you multiply by 80, you get a reading with the dyne unit. Just last slide. Like I said, the limitation for your pulmonary artery occlusion pressure, it's not, we call it wedge, but it's not a truly wedge, or it's not a capillary pressure measurement. it does not give you the left ventricular end-diastolic pressure measurement or the volume for that matter. It's affected by, these factors, the compliance of the ventricles, the pericardium, intrathoracic pressure, mitral valve. So you have to make all these assumptions before you say that I'm looking at the preload by doing or by measuring my pulmonary artery occlusion pressure, because that assumes that you don't have any mitral valve disease, you don't have any pulmonary vascular disease, you assume that your left ventricular compliance is normal. So, but any of these factors can affect your readings. So what you get here at the end is not going to be a reflection of the volume. So if you are looking to see if patients are volume overloaded or not, with other factors being in a place, your readings is going to be misleading. So I'm going to leave it here for today, and tomorrow we'll go over some questions, things that you might expect to see on the board.
Thank you.
Thank you. Okay, and I'll put it here on the screen. Anyone who is interested, you can upload it from the screen.
Thank you.
All right, thanks.